Welcome everyone to the Maddie Riewoldt's Vision 2026 series of patient and family educational sessions on bone marrow failure syndromes. My name is Jaya Soman. I'm the Research Project Manager at Maddie Riewoldt's Vision. Before we start, I'd like to acknowledge the traditional owners of the lands on which we are meeting, the Wurundjeri people. I would also like to pay my respects to their elders past and present and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. Maddie's Vision is the only organisation in Australia driving bone marrow failure syndrome research, advocacy, education, and support for patients and families. We have now committed 10 million across 37 cutting-edge research projects and have multidisciplinary collaborations in place with leading research institutes across Australia and internationally. We are the source of support for bone marrow failure syndrome patients and family members through our telesupport service and our peer support program. We have now supported 180 patients and families nationally and invite any of you here tonight who have not connected with these services to please reach out. Our program this evening will explore fertility preservation, covering both clinical decision making and the practical considerations for patients and families. We'll then have a question and answer session, and we thank everyone who has submitted questions prior to today. Our speakers have endeavoured to cover these in their presentations. However, if you would like expansion on certain topics, then please do let us know during the dedicated Q&A. I'm now absolutely delighted to introduce our first speaker, Associate Professor Kate Stern. Kate is Head of Reproductive Services and Head of the Endocrine and Metabolic Service at the Royal Women's Hospital. She's also the Clinical Director and Head of Clinical Research at Melbourne IVF. Her special interest in research focuses on medical fertility preservation for young people affected by cancer and other serious diseases. Kate will be speaking tonight on preserving and protecting fertility for the future. I'll hand it over to Associate Professor Kate.
Thank you so much, Jai. And can I just say, first of all, thank you so much for having Aisling and I tonight. And we're so excited to be chatting with you and your families. What an amazing organisation. And I know from patients the extent of the support. It's not just scientific support, it's family support, and you are so important and you do such an important job. I'm just going to share my screen now. So let me know if there are any problems with my screen. Can you all see it? Is that fine? I'd like to talk with you tonight about protecting future fertility. So this is fertility for the future for young patients who are having bone marrow transplant, autograft, or significant treatment for hematological conditions. I'll look forward to your questions also at the end. So first of all, I just wanted to let you know that we do get support for our program from the Royal Women's in Melbourne and from the In Time for our In Time program from the Children's Cancer Foundation and My Room. And importantly, also additional support from the Sony Foundation. And without this support, we would not be able to reach the families and the services that we reach. So I'm very, very grateful for that. So what we're going to talk about first is why we do it. Why do we do fertility preservation? And that is because these treatments can have a big impact on patients' ability to have kids in the future. We're going to talk about options for girls and young women, for boys and young men, and then how to make it all happen. So why do we do it? This is why we do it. Over 80% of young patients will recover from their cancer treatment or their other serious hematological condition. And these young people will go on and expect and want to have their own families. And the threat to fertility, it's a second big blow and blight because not only is there the trauma of the diagnosis, and the trauma of the need for treatment. But if these people can't have their own children in the future, it's an extra enormous burden. And so that's why we do it. And when we first started doing these in the mid-90s, I'm very old, we were driven to this by our patients. It wasn't that we were clever at it at all. It was our patients and their families coming to us saying, what can you do to help my kids or to help me in the future? And, that's what's driven this enormous development in accessibility and research and clinical programs. Now, I think you all know better than I do that when you have an autograft or a bone marrow transplant, the chemo that you have prior is used to wipe out the cancer in the old bone marrow, and then you put new stem cells in to grow healthy bone marrow. The problem is that the treatment to get rid of or damage or obliterate a patient's bone marrow so that they can have the new bone marrow or stem cells damages the eggs and the sperm and their surrounding cells in addition to damaging the bone marrow cells. These treatments absolutely damage rapidly dividing or active cells, and that's why the eggs and the sperm are so vulnerable. Now, the chemotherapy regimens and radiation, they all have different risks. And we try and categorize it into low risk, medium risk, high risk, and really, really high risk. Okay, so low risk treatment would be for patients that were perhaps having ABVD for Hodgkin's disease. Medium risk would be treatments that involve cyclophosphamide, Birkhoff for Hodgkin's disease, CHOP for Hodgkin's. High risk are the conditioning chemotherapies, and very high risk are the treatments involving high dose chemotherapy and radiation. And the problem is that transplant patients have a very high risk of having their gametes, their eggs and their sperm damaged, and they lose their potential fertility. Interestingly, with the treatments that we have now more for autograft with patients' own stem cells, the conditioning chemo is not quite as damaging, which is good news. Often the damage is permanent. And although sometimes it's temporary and you can't tell if it's going to be temporary or permanent. So this is a bit of a hard thing to get your head around, but let's just go through it together. So a patient would have chemotherapy, and if they were already having periods or they were a young boy who had already started having sperm production, it's almost certain that you will get a temporary loss of eggs and sperm. But usually it will come back, but it's not going to come back for good and last as long as it would have. It comes back, but not as robustly. But some patients, unfortunately, having high dose conditioning treatment prior to bone marrow transplant, it's what we call permanent ovarian insufficiency. That is, the eggs and the sperm will not come back to be functional. And that ends up in what we call permanent ovarian failure or menopause and permanent loss of sperm production for men. So it's important to note that often it'll come back for a while and could be quite good, but it almost inevitably stops working down the track. This is how I think about it with eggs. So it might have been because I really love chocolate freckles, but when I tried to work out a way to illustrate it, the first jar is, let's just say that that's all the eggs. And so you have low risk treatment. It's not going to get rid of most of your eggs. But if you have moderate risk treatment, it might reduce your egg number. The chemo might damage your eggs and kill some of the egg cells, and you might have 2/3 of or 3/4 of your eggs left. But if you have very, very high risk treatment, it's very likely that the jar will be almost empty. You won't have many eggs left, or you might have no eggs. If you have TBI, total body irradiation, that can also contribute. But the stuff that's really bad is actually when you have pelvic radiation, not the TBI, but the radiation to the pelvis. That will really affect your egg production and damage your eggs. And it's not just about the eggs, it's about the hormones. And that's really important for young girls because not only do you need the eggs, but you need to have the hormone production for puberty and for your bones, etc. So that's how I imagine it. So, sorry, this is a bit of a funny slide. I tried to make a slide with, because the things that I like nearly as much as chocolate freckles are jelly snakes, but I didn't have any jars at home, so this will have to do. It's the same thing for boys and young men. Low risk treatment really isn't going to destroy most of the sperm cells, but moderate risk treatment will destroy a significant number, and very high risk treatment might really damage the sperm. So, what options do we have for our young patients for the future? We can take eggs, we can take ovarian tissue, and we can take sperm, and we can take testicular tissue. And I'm just going to talk about this a little bit more. I hope you like these pictures. Every time I look at these pictures, I get a little buzz of excitement about what we can do to help our young patients. So, the first thing we can do in girls who have already started having periods, if we've got enough time, is 10 to 14 days of hormone injections with little injections every day. And we do ultrasounds on the tummy or internally in older women. And then after about 10 to 12 days, hopefully we've got quite a few follicles, and we do a little procedure where our patients go to sleep. They're not actually, it's not a general anesthetic, they're under sedation. And then we put a needle into the ovaries, into those follicles, and then we get the eggs. And then the eggs get frozen that day and they're stored. And what is amazing is once they're stored, they're there, right? Nothing changes. Once they're stored, they're there. I just want to show you because this is so beautiful. This is an egg, and this is an egg that has been frozen and thawed out. And in this young patient who had her eggs taken at about, I think she was about 24, later on when she couldn't have children herself because she didn't have any eggs left, we thawed out her eggs and we fertilized them with her partner's sperm. And this is what we did. We could make an embryo. So I just want you to look at this. I've sped this up, okay? This is 5 days. We'd all be pretty bored if we took it over 5 days. So this is 4 cells. So that's 2 days after the egg's been fertilized. And you can see what's happening is it's getting more and more cells. It's such an active, dynamic process. And this egg, which has been fertilized, is now an absolutely beautiful embryo that we're ready to put back into that young patient. And when we get that embryo, that's got a good chance. It's about 35%. It's not 100%. I wish it was. So that's what it looks like down the track. It's so beautiful. So for egg freezing, we can do this for patients that have already started having their puberty, who have started having periods. There is the potential to do it a bit earlier, but the results are not very good. It requires 10 to 14 days of hormone injections. Our success rates are excellent. When we have frozen eggs, it's amazing. They just behave the same as fresh eggs. So if someone was undergoing IVF, we would use the same statistics. And all IVF units are pretty good at this. So that's a very good thing to be able to do if you've got the time. Now, you might get heaps of eggs or not many eggs, but it's a good thing to do. The other thing that we can do is we can take a piece of ovarian tissue. And I'm just going to walk you through this because you've got to do a bit of imagining, right? So we do a little operation. It's called a laparoscopy and it's keyhole surgery. So a little camera in the belly button and 1 or 2 other little tubes going in with graspers. And what you can, I'm not sure if you can see my pointer, but what you can see here, this is the tube and this is the ovary. And see the little grasper is attached to the ovary. So what we do is we take a little bit of ovarian tissue and we cut it out of the ovary and then we take it out of the body and we look at it under the microscope and check that it looks good, that it's got little eggs in it, and then we put it in the freezer. And this is actually very real because our fertility preservation storage canister is hot pink, the one we have at our work. I think we had a bit of influence on that. Now, if a young woman does not have any ovarian function after her treatment and she's got tissue frozen, then we do another little procedure and we pop the slices of tissue back in the ovary. Actually, we can put it not just in the ovary, we can put it in the tummy wall. And get this, that tissue, as long as it can get a blood supply, that can make eggs again. It's pretty amazing. It's hard work, it's a slog, but it gives our patients a very real opportunity. And in our program, just at the Royal Women's and Melbourne IVF, we've had 16 or 17 births and we've got 2 more pregnancies. So these are girls that had no other option, but they'd had their tissue taken and then their ovaries weren't working. So we did the little operation, popped it back, and it made eggs again. Pretty amazing. There have been about 250 or 300 babies born around the world. So what's good about ovarian tissue freezing is that we can take tissue from young girls, even babies. It does require a little operation, okay? But it is one day. It says 1 to 2 days, but it's not. We do it just over 45 minutes and take the tissue. So if we get a call saying, I've got a young patient, I've got to start high dose chemo tomorrow, can you do this in our program? And Aisling will tell you more about that. We can do the little operation if the patient is well enough and freeze the tissue. So it's not called experimental anymore. It's called, what's the word? Innovative. So it's not classed as experimental. Currently, this is the only option for girls before their periods or for girls that don't have time or young women. Now, I have to say that from tiny tots that have had their tissue taken, we haven't put tissue back because we've only been doing it for a few years, but the experimental studies show that the tissue still works even if you take it from a little patient. What about boys and men? I love this photo. This photo is of beautiful sperm. They all look pretty normal. Unfortunately, it's AI generated, so they look more neat than they normally do. For boys who have reached puberty and are able to ejaculate, we can have a sperm sample. And we can freeze the sperm, we can leave it there, and then we can use that sperm later if we need to inject into eggs. So that's good for young men and for people that can ejaculate after puberty. Although I have to tell you that sometimes it's very stressful and, we're trying to ask these kids to do an ejaculator sample and it's just too much hard work. So we do have other options. So the other option is to put a little needle in the testis under anesthetic and we can freeze the tissue. So we can do that for anyone, any man or boy. For pre-pubertal boys, it's a bit like the ovarian tissue that we can take the tissue, but we still call it experimental. Now, just hot off the press, there's a publication a couple of weeks ago. So a group put some tissue back when they'd taken it from a boy before puberty, and they're not trying to make babies for him, but they were trying to test to see whether the tissue could make sperm again. And it did. So that's still experimental, but we're very hopeful. So which option is right for who? This is a decision that a family will make with their fertility specialist and with their oncologist and their hematology team. If we've got time and post-pubertal, we can freeze eggs. If we haven't got time or girls younger than before their period starts, we can freeze tissue. And sometimes I have to say we do both. Sometimes we can freeze tissue and eggs. We can bank sperm when we need to, and we can do testicular biopsy at any age, including young boys. Now, I've just said it as if, oh yeah, it's really pretty easy, blah, blah, blah. It's not. But what happens is hematology units and oncology units make time for their patients to have these conversations and to have more than one conversation with the team. So there's always time to work through it, and you'll get very good objective guidance. It is a special area for kids before puberty. And now our national guidelines say, yes, you've got to talk about this with families of young kids, okay? It's really important. And the guidelines say it. Now, the fact that the guidelines say it doesn't mean everyone does it, but we really want our patients, and we're trying to get the message out both to healthcare professional groups, but also to our patients and our families to be empowered to say, I want to talk about this. I know we're in a hurry, but get me someone to talk to. So you've always got to make sure that you can do that. So it's important, as I said, to know that you can talk to your team. If they haven't raised it, you can talk to them. And we have very, very close relationships, particularly in Victoria, but all over Australia now. And Aisling, who's in charge of our program, is really working hard all around Australia, even in country towns, to make sure everyone is aware of this. And we link you in with fertility specialist programs. The procedure will be done, and it's very important. Yes, you can start your treatment, but you must hang in there and have follow up with your specialist, because it's not just about the eggs and the sperm, it's about the hormones. And secondly, often it'll have been such an amazing blur, and it was all so stressful and traumatic, and you just did what you were told. And then afterwards you think, oh my goodness, what was that? And so we really like to be able to talk to our patients. We make appointments for our patients for 3 months, 6 months, and then almost yearly down the track to be able to follow up. So don't worry, you're going to be supported all the way. So just remember that the transplant treatment does have a risk, and that's why it's so important to be able to have a chat. And you might not always be able to do it, but it's important to have the chat, because the specialist will tell you what options are available if we can't do it. So ask your team today. Always feel empowered to ask the questions. We have a great national onco-fertility program with government support. We've got a dedicated hotline, email, fax, everything, whatever. We've got lots of resources, both for healthcare professionals and our families, and they're very receptive. We will see families really quickly. We will talk to families. We can do telehealth all around Australia, and actually we do it in some patients are overseas as well. I just want to say again, thanks so much for the opportunity to talk to you about options. And I'm sure Cherie and Jaya will make available links and resources, and we're always happy to chat. Thanks so much for listening.
Thank you so much, Kate. That was such an insightful overview of fertility risks and the options available to preserve future fertility, and a real great foundation for helping to understand why these conversations are so important early on in the treatment process. I have seen one question, so I'll just remind that we will have a dedicated Q&A at the end, but thank you so much for popping them in the chat, and we will address them later on in the session. I'm now delighted to introduce our second speaker, Aisling Murphy. So Aisling is a clinical midwife consultant for the Fertility Preservation Service at the Royal Women's Hospital in Melbourne. And Aisling will be speaking more about the practical aspects of accessing these types of services. Thank you so much, Aisling.
Thank you so much, everybody, for joining us on this Thursday evening. I know usually this is the time that you'd be snuggling down in your couch and I suppose, watching something exciting on the television, but this is our passion project and we're so happy to share, all of our knowledge and resources with you. So thank you so much for joining. As Kate was saying, and Jaya there for the lovely introduction, I'm Aisling and I work over at the Royal Women's Hospital for the Fertility Preservation Service. And I'll be speaking to you this evening about accessing those service and just some other kind of friendly tips and tricks that are out there on how to navigate this space. But first of all, I'm not sure, can you see my face while I'm sharing the screen? I'll just lower that down. There you go. I don't know if I can move it. Anyway, it's going to live up there. Nothing as important as up there. First of all, I'd just like to introduce Maya and Sheila Patel. So, as Kate was saying, our fertility preservation service has been within the Royal Women's Hospital since the early 90s. I know Kate was saying that she's much older than us, but it's not that long ago. And recently, from our generous donation from My Room, the Sony Foundation, and Children's Cancer Foundation, we were able to kind of expand our fertility preservation service and onboard some consumers who have been so amazing in helping us kind of shape more of a consumer lens to fertility preservation. I know historically it's been very kind of clinician focused, and we have absolutely relished the opportunity to speak to parents and children and young adults all across Australia on their experience of the service so far. So I just have a little bit of a story here from Maya and Sheila that they've given me permission to read out. So when Sheila's 3-year-old daughter Maya was diagnosed with stage 4 neuroblastoma, the focus was rightly on saving her life. She underwent intensive life-saving treatment, and today she's a vibrant 15-year-old who's cancer-free with big dreams and a strong support network. So while Maya lives with some long-term effects of treatment, her story highlights an important shift in how we care for our young patients. Today, we recognize that survivorship is more than a cure. It's about the quality of life and future choices, including the possibility of having a family. So for patients diagnosed now, there are fertility preservation options available before treatment begins, helping to protect those future choices. And even after treatment, there are still pathways to parenthood, such as donor eggs, surrogacy, adoption, that can offer meaningful opportunities to build a family. So Maya and Sheila are such powerful advocates for this progress, and their story reminds us that while we've come a long way, we still have quite a little bit to go, I suppose, down the line. So thank you so much for Maya and Sheila for helping us kind of shape this. No, why can't? There we go. So the importance of having a conversation. So as Kate mentioned, there are so many guidelines out there for us in the healthcare realm about why it is so important to have the conversation early on. And although it's written in the guideline, it doesn't necessarily mean that it happens every time. So I know it says here cancer treatments can affect fertility. All treatments can affect fertility, hematological, genetic conditions, autoimmune conditions, and there are many options exist out there to protect that fertility. And as Kate said earlier on, acting early can give you more choices. So the window of time, just brushing past this again, obviously the best time to preserve any fertility would be prior to the commencement of treatment. Depending on where you are in your menstrual cycle or your reproductive stage, there are some options that exist whilst on your treatment. And then after treatment, although there is a significant risk that your fertility has been affected, there are some options still out there for you. So during treatment, again, is the best time to preserve. And like I said, that hormonal protection does exist that some of you may have had in the past, that Zoladex or that Ganirelix treatment. And you can often do some cycles of either egg freezing, tissue freezing, or sperm freezing between your cycles as well. And then after treatment, again, just brushing past this because Kate said it much better than I can. But I suppose discussing those family building options after treatment as well. So just because your treatment has finished, it doesn't necessarily mean that this chapter is closed, and that a conversation should still happen regardless of where you're at, whether it's just after treatment, 6 months, a year, 2 years. Our door and fertility specialist doors are always open to have a conversation with you and help you kind of build up from that. So how to access the services in each state. So I'm very lucky in my position now as coordinator of the In Time program, which I'll speak to in just a little bit. But I'm very fortunate to have created a network for our clinical nurse consultants, our clinical nurse specialists, to get together in one room and kind of share what fertility preservation looks like within each state. I've made some great friends along the way, and everyone is such kind of a powerful advocate for fertility preservation. So it's so nice to have some traction on that to really kind of get the information out to the people who need it. So the referral process pretty much starts the same way in each state. And it goes by speaking to your oncologist or your hematologist or oftentimes your GP as well. About asking kind of how best to connect with a fertility specialist. Each clinic has their own kind of fertility preservation referral form. But it doesn't matter. Your GP can write a letter, your specialist can write a letter to those fertility clinics. Depending on where you're at within your treatment, before your treatment begins, you would be deemed as urgent. And the majority of fertility clinics have kind of a timeline that they need to meet, which is often same day or next day appointments, which is fantastic. And that way it kind of gives us a better chance to get to know your timeline and kind of fit it in as best with your treatment. And then if you're after treatment, depending on how urgent it is as well. So if you're someone who's experiencing some premature ovarian insufficiency or premature menopause, it's not something that we take lightly. And clinics definitely try and fit you in as early as we possibly can. And then there are funding options as well, which I'll speak to in just a minute. So like I said, we've created this network now, and these are all of the pediatric, adolescent, children's hospitals that we've connected with over the last year, which has been fantastic. I'm not sure where you all are this evening. Obviously very Victorian bias, working within the Royal Women's Hospital. And we've made great connections with those in RCH, Monash Children's Hospital, some fantastic connections down in Tasmania. And New South Wales has really kind of helped shape and guide kind of what we expect or what we would like our program to look like. But we've made such great connections, so many referrals from these wonderful centres. So within Victoria, we are very biased. We do have public fertility care available, which is now 3 years old. And it is backed by the Victorian government, the Department of Health. It's accessible via GP or specialist referral. We offer free and/or low-cost services, including IVF, IUI, and ICSI, which are those kind of treatments that Kate was speaking about. So it would be egg freezing, embryo freezing, and then going down the line if you're looking to create a family or have an embryo transfer to fall pregnant, as well as genetic counseling, donor support options, surrogacy support options, and a public egg and sperm donor bank as well. So we've got it all. But it's so amazing, I suppose, to have this finally within Australia, something that will hopefully kind of shape more publicly funded fertility care in the future. So as I might have said in the beginning, if anyone has any specific contact detail questions about these states or hospitals or clinic, feel free to just pop them in the chat and I can pass them on to the team and you can get the information that you need. So within Queensland then, they do have a statewide fertility preservation service. And I believe the department up there has promised a $42 million investment to fund this assisted reproductive technologies or IVF or fertility care, including those that are cancer related and non-cancer related as well. And again, I have the contact details for this statewide service. We are in kind of constant communication with them. New South Wales, then, as I said, they do have a statewide fertility preservation service. There are some kind of conditions to the program. They obviously would see patients urgently, semi-urgently, and non-urgently. But for those patients post-treatment, I do believe that they have kind of a 5-year cap. So in order to access the government-supported fertility preservation program, you need to be within 5 years of ceasing your treatment. But I suppose for those early patients, they do make exceptions here and there. So for South Australia, Tasmania, ACT, and the Northern Territory, unfortunately, there are no or limited publicly funded fertility services available. but patients and families are always encouraged to speak with their GP or their specialized gynecologist, andrologist, or endocrinologist. And they can always come and have a chat to us. So our fertility preservation service, although we do run off of public fertility care that is Victorian based, we do run a nationally funded program as well, which I'll speak to just after these common questions. So Kate answered a lot of these, but I suppose just to kind of rehash them, will this delay your treatment? So it very much kind of depends on where you're at your diagnosis. So typically, you would be given an enough amount of time prior to your bone marrow transplant that would enable you to at least have a fertility preservation consult with either your oncologist, your treating team, or a fertility specialist. So in most cases, no. And although we're such strong advocates for fertility preservation, at the heart of it, the patient or yourself or your child, you need to be focused kind of on your treatment. And although there wouldn't necessarily be a delay to that treatment, you do have to take into consideration, I suppose, some safety concerns. So for the tissue collection, let's say, it would require a general anesthetic, and you or the patient needs to be, clinically well to undergo that general anesthetic. So will it delay treatment? No. Is it safe? Absolutely. But I suppose there are some indications that would kind of make space for pause and say, is this the best decision for you right now? Or depending on, I suppose, the element of risk involved in your treatment, is it something that we could pause and revisit down the line in a few months' time and get you started on the conversation and the options again? What are the chances of success? It very much kind of depends on your age or diagnosis and the risk of the treatment that you have received. So like Kate was saying, the options out there for eggs and sperm and ovarian tissue would, have gold standard, fantastic success results. And those kind of more innovative or experimental options, such as, pre-pubertal baby ovarian tissue freezing and testicular tissue freezing. There's so much research out there going on at the moment that, I have no doubt that in 10, 20 years' time, when patients reach that kind of reproductive age, that will have so many more options available and hopefully more studies coming out. So what happens long term? So the storage of your tissue, your eggs, your sperm, your embryos, they're all frozen in time. They're not going anywhere, and they don't have an expiry date to them, which is incredible. And so kind of how long you keep them in storage is very much up to you. I do have a little slide on storage just coming up as well, which is here. So they are stored long term. They are, I suppose, physically stored indefinitely, but there are some kind of rules attached to it. Typically, if you are over the age of 18, you would have your gametes or your eggs, your sperm, your embryos, your tissue stored for 10 years. And after 10 years, what happens is we reach out and we contact you, and we would ask you if you would like to use them, dispose of them, or continue your storage. So there's an option there to continue the storage indefinitely. It's just you need to maintain that kind of relationship, with the fertility center to kind of make your wishes known. And those who have items stored who are less than 18 years of age, there's a caveat there that, if you're 10 years old and you have ovarian tissue frozen, in 10 years' time when you're 20, the likelihood of you wanting to have a baby at that point would be relatively low, or it might not. But we do have a caveat in there to say on the consent form that you will have to store it you can store it for 20 years. But there will, depending on where you have it stored, there will be kind of checkpoints just to make sure we still have your correct phone number, your correct address, your correct email address, so that if that amount of time surpasses, that we still have that connection with you and you can just tell us what you'd like to do with it. And then, it's guided by the medical and the legal frameworks. And if there is kind of any updates to the storage, it makes it easier then for us to be able to contact you to tell you kind of what those updates are. So our national fertility preservation programs. So here in Victoria, over at the Royal Women's Hospital, we offer free fertility support on ovarian and testicular tissue transport, freezing, and storage, as well as a pre and post consult with one of our fertility specialists or consultants or fellows, oftentimes myself as well. So procedures are done locally. Under your Medicare rebate. So if you're up in Queensland, we would get the referral, we would contact a team, they would either have a conversation with you or you can have a consult with us. We would go through the logistics of what the best option for you would be, and then you would undergo your tissue collection in your own kind of hospital. If you're a minor, typically it's combined with another procedure. So if you are having a line inserted or a biopsy done, we would just kind of piggyback off of that general anesthetic and collect the tissue then. Your tissue then would be transported down here to Melbourne, where we would have a look at it under the microscope. We would freeze it and we would send you a letter in the post with the final kind of freeze result. And then we'd book you in to see Kate or our other fertility specialist here at the Royal Women's, Jenny Rosen. So important to note that although we have these two programs or a program that offers fertility preservation nationwide, if you do have an oncology diagnosis, so a cancer diagnosis, the transportation would be fully funded. And those with a non-oncology diagnosis, there would be a transportation fee, which varies from site to site, but the consult with our fertility specialist and the storage of your tissue would all be absorbed as well. And for those interstate patients without a valid Medicare card, there may be a fee associated with the consult, but it's very much based on a case-by-case basis. And we really do try our best to limit costs as much as we possibly can in those circumstances as well. So to be eligible for our tissue preservation programs, which again would not be made possible without the very generous support of MyRoom, CCF, and Sony, you need to be between the ages of 0 to 30 and at risk of losing fertility due to a cancer or a non-cancer diagnosis. And as I said, the transportation, the freezing, and the storage then would all be free of charge. So for those patients who have previously stored eggs, sperm, or embryos before their treatment, and there might be some people kind of out there who are currently paying fees for that. If it was kind of before the time of public fertility or those kind of low-cost fertility preservation programs, they launched a national storage funding program to cover the costs of those items for patients who have had their fertility affected by high risk kind of medical need or genetic need. So you need to have a valid Medicare card and patients with a history of cancer slash, a medical reason to freeze, or those who require PGT. So you can scan the QR code there. Just important to say that tissue is not on this national storage funding program, but the tissue within the Royal Women's Hospital as part of those two programs is absorbed as well. And I know I'm over time. There are so many resources out there, guys. The Canteen Maybe Later Baby is such a fantastic resource. So easily kind of readable. It was consumer made. It's absolutely fantastic. We have so many resources here within the women's to help you make that decision. And we've recently made some more resources around ovarian and testicular tissue freezing, which I'm more than happy to share with you as well. So the essential points and takeaways, always, always, always talk about your fertility if it's something that is on your mind. If you're pre, during, or post your treatment, we're here to help. We're here to give you the confidence in kind of making a decision or a choice, and really kind of just protecting your future fertility options that are out there. because, as it says there, your future family is worth the conversation. And thank you so much.
Beautiful. Thank you so much, Ashlyn. That was just such a great overview of very practical, reassuring overview of the way patients and families can access these types of services and supports along the way. Huge thank you again to our guest speakers, Kate and Ashlyn. Your presentations were amazing, and you've such a wealth of knowledge and insight into this area of it, this, which is a very important considerations to make for patients and families. So we thank you again, and also to all attendees for coming to this evening. We really appreciate your input and participation, and we really want to ensure that our work is represent your lived experience is represented in all that we do. So thank you so much. We'll be sending a short survey on Monday. We really appreciate your feedback, as it does help to inform how we can improve these events in the future. We will have our next session in July focusing on Shwachman-Diamond syndrome. So there'll be further information in the coming weeks on that session. We hope to see some of you there. That now concludes the formalities for the evening. So I wanted to thank you all again for attending this evening and wishing you a good evening. Thank you so much.